start. Good evening, all. We are a small group today, so I guess the discussions are going to be very intimate and intense. So that's a good thing, also. And besides, for anybody who misses the lecture, we're recording it also. So I'll just introduce our speakers today. One second. So this is the 17th meeting for the Ocular Genetics Interest Group, and we have Dr. Sonam. She's an associate professor at the Advanced Eye Center at PGI Chandigarh and specializes in cornea, cataract, and refractive surgery. She has a keen interest in ocular imaging and pediatric cornea and has published several articles and book chapters. She is also the editor of the Chandigarh Ophthalmology Society newsletter and has participated in various national and international conferences as a presenter and won several awards. Welcome, Dr. Sonam. Our next speaker is Dr. Deepika. She's a consultant ophthalmologist at Narayana Nethralaya, whose area of focus is vitreoretina, inherited retinal diseases, ocular genetics, and electrophysiology. And she completed her extensive fellowship in retina and vitreous at the prestigious Anand Bajaj Retina Institute at LV Prasad. And she serves as a faculty member and assistant ophthalmologist at the same. She has served, and she also has several publications and presentations at both national and international scientific conferences, and her research focuses on inherited retinal diseases and development of new therapeutic modalities. With that, I hand over the platform to Dr. Sonam to speak about bilateral congenital corneal opacity with the FANCA RTS overlap.
Thank you, Dr. Ria. So, okay, so I'm sharing my screen now. All right. Is the PPT visible to everyone?
Yes.
Right. So, very good evening, everyone. And this is my first presentation in this interest group, and I'm really grateful to Dr. Shailja and Dr. Ria and the team for giving me this opportunity. And I selected this case for this particular evening presentation because this case was like a dilemma, and it taught me a lot. And I am looking forward to a good discussion on the same. So there's this child of a bilateral corneal opacity with a lot of phenotypic and genotypic overlap. Okay, move to the next. Okay. So the 9 months old male child was brought by his parents. They are resident of Jammu and Kashmir, and they presented to our clinic with complaints of whitish discoloration of the both eyes noticed by parents since birth. And this whitish discoloration was also associated with generalized edema of the body along with edema of the lids, and the child was unable to open his eyes fully till almost 1 month of age. Other than that, the developmental in the birth history was not that significant, but yes, there was this history of NICU admission and some ventilatory support, but the child was term, and the child was also born at home, and has achieved other milestones and was immunized completely. And coming to the family history, there was history of third degree consanguinity in the family, but no other family members were having any ocular complaints. So coming to the general physical examination of the child, he was alert, playful. Along with that, we can see that there was presence of a dysmorphic facies, and just the general respiratory and cardiovascular system examination was normal. And doing deep phenotyping of the face and the body, you can see that there is presence of epicanthal folds, ptosis, broad nasal bridge, dysmorphism of the face into like overall, and long philtrum, a thin upper lip. We can see there was presence of this bilateral preocular sinuses, and brachydactyly. You can see the short stubby fingers. Cafe au lait spots were present in the child, along with the edema, and enlarged genitalia was also seen. So coming to the ophthalmic examination, there was the child was not able to fix or follow the light properly, and there was no nystagmus, but there was esotropia, mainly due to the broad nasal bridge, and there was presence of ptosis in both eyes. And on doing a detailed examination of the anterior segment in the form of an EUA, The axial length of both eyes were like more than 21, and intraocular pressures we could not get because
इसमें ना एक बंदा है उसका ना पेमेंट का लिंक ही नहीं है उसको मैसेज कर सकते हैं क्या
hello, yeah,
कर दिया शाम को
okay, I'll just go
Everyone,
ahead.
please mute your mics.
So the intraocular pressure we were digitally low, but we could not get exact pressures because of the irregular Myers. And we can see there's on everting the lid, there is presence of a sclerocornea-like picture in the right eye, especially we can see this limbus is not well delineated in both eyes. Along with that, only the central small island of cornea can be visualized. There's presence of cornea plana. Other eye, we can make out more of the cornea, but still there is presence of a sclerization of the cornea. On ultrasound, there was anechoic vitreous cavity, but there was query optic disc cupping or query excavation of the posterior retina, suggestive of a coloboma. So this is the right eye UBM. We can see that the cornea is quite thickened, and along with that, it appears very compact with this increased hyperreflectivity of the cornea from limbus to limbus. And there's presence of this ASDA, that's anterior segment abnormality. We can see this iris is stuck to the endothelium. And in the center, we can see some hyperechoic shadows. These hyperechoic shadows could either be suggestive of, dysplastic lens matter. So the lens actually was not completely formed, because beyond this, below that, we can't see any lens shadow. Coming to the left eye, we can again see the compact corneal stroma with increased hyperechogenicity. And there is this lens, which is cataractous lens, which is totally stuck to the endothelium along with iridocorneal touch. And we actually wanted to look at the visual prognosis. So we did a VP where in the right eye, there were no clear waveforms, but in the left eye, there were waveforms, but there were prolonged P100 latency was seen. And we explained to the patient, in view of the dysmorphic facies, the child should be getting a review from the pediatrician along with the geneticist. And a systemic workup was then ordered in the form of echocardiography, which was normal, and ultrasound abdomen KUB and ENT examination to look for any hearing disorder, along with the preauricular sinus, which we saw that was turned out to be normal. But on doing a blood investigation, we saw that child had very low hemoglobin. Along with that, hematocrit levels, MCV, MCH was low. These are all suggestive of iron deficiency anemia, because there's microcytic hypochromic anemia with presence of a thalassemia trait. And this is the genetic examination on the whole exome sequencing of the child. We can see there is presence of CREB heterozygous mutation at exon 2 of CREB gene, which was autosomal dominant, suggestive of a Meniere-Hennekam syndrome type 1, which was of uncertain significance according to the ACMG criteria. Second mutation that was positive in this child was a homozygous mutation at exon 34 of the FANCA gene, which was autosomal recessive, suggestive of Fanconi anemia. Again, it was of uncertain significance according to the ACMG criteria. So keeping these two mutations in mind, we got a Sanger sequencing of the parents as well, even though the parents did not have any ocular features or any other systemic features, significant systemic features. So we found that there is presence of this FANCA gene mutation. So here I want to emphasize that the Sanger sequencing after consultation with the geneticist, the FANCA mutation Sanger was done, but we have not done the Sanger mutation. So at this point of time of the CREB gene. So the mother as well as the father had this mutation present in the autosomal recessive form, but mother here had a homozygous mutation, which again was kind of baffling for us because the mother is totally asymptomatic. And then we did a little bit of literature review where we could find this particular article by Dr. Ken Nischel's team, which showed that's the first ever report of FANCA gene mutation showing bilateral corneal opacity with anterior segment dysgenesis. And here, if you look at the picture on the right side from this case, this is exactly like more or less looking like our picture, not the same picture, but more or less. And here also there's compact, thickened corneas, compact corneal stroma, along with that iridocorneal touch. And the histopathology was described to have absent Bowman's membrane and a very thinned out endothelium. So keeping these two things, mutations in mind, we just wanted to read, because the Menneke-Hennequin syndrome was something new, which I had not come across earlier. So it was a rare, recently described syndrome, which contains of exon 30-31 mutation in the CREP gene, and also the EP300 genes. These are the two genes which are responsible for this syndrome. And they are actually the products of these genes lead to acetyltransferase activity for the histones and various other proteins. And these mutations want to be mainly de novo mutations. And the children usually present with intellectual disabilities like autism, or maybe feeding difficulties, short stature. But ocular features, if we were looking into the details, we could not find very significant ocular mutations. I'm going to come to that in the next slide. And this mutation, particular mutation, that is the CREP gene mutation, is more studied for the Rubinstein-Thebe syndrome, which is again having the distinctive facial features in the form of broad nasal bridge, and the patient could have angulated thumbs and short stubby fingers, short stretchers, and palpable. They could have thin lips, grimacing smile, and tail on cusp, basically the teeth. So again, in these two mutations, the CREP BP and EP300 mutation is known, which is again overlapping with that of Menneke-Hennequin syndrome. But in this particular mutation, you can see the mutation along all the exons of these two genes, unlike the Menneke-Hennequin, which is typically described for exon 30 and 31 of CREP gene. So facial phenotype, again, of the Menneke-Hennequin, which we were talking about, patients have thick eyebrows, flared eyebrows, broad nasal bridge, high palate, thin lips. And other than that, in literature search, I could only find myopia, hyperopia, and strabismus as the features, but corneal opacity with anterior segment dysgenesis was not described in literature so far. So in our case, we have this unresolved genotype-phenotype correlation. First being the exon 2 mutation, which I told that Menneke-Hennequin syndrome is not typically seen on this exon 2, which is more suggestive of Rubinstein-Thebe syndrome. And the mother has a homozygous mutation on the Sanger sequencing, still no clinical manifestation. So why the genotype-phenotype gap? And what next? We have already ordered the CREP BP mutation to clarify the de novo mutation for Menneke-Hennequin. And we also wanted to see whether there's a role of consanguinity, which is leading to both the mutations overlapping in the child. Ultimately, this child underwent keratoplasty in the better eye, that is the left eye. And we could see at the EUA that there was presence of a fundal coloboma, type 1 coloboma in this eye. And OCT also, we can see the presence of this posterior capsule, and the graft did quite well. And ultimately, we gave visual rehabilitation in the form of aphakic glasses, and the child is able to fix and follow light with plus 13 diopters lens. According to Cardiff, it's at least 6/120 vision. And quickly, I want to go through this child's histopathology report. And here we can see that there's this intact epithelium. Bowman's membrane was present in this case, and there was this irregular arrangement of the collagen fibers and a very thinned out Bowman's Descemet's membrane. And we also got the electron microscopy, which again showed the irregular arrangement of the collagen stroma, suggestive of sclerization. So this is the journey of this child. So now this is open to discussion. Thank you very much for the opportunity.
Thank you, Sonam. Wonderful case. Yeah, very good documentation also. I was just wondering that could this be a dual diagnosis? Because your the FANCA gene, it is like probably the anemia is coming from there.
Yes,
And from the CREB, it's probably the ocular findings which are coming there.
yes.
So I was just checking out, because I was thinking why the mother is not having, and I was seeing that FANCA gene is known to have some incomplete penetrance,
Yes.
and also some genetic variability, heterogeneity that's
Yeah.
in the way. So maybe that explains why the mother is not having any manifestations, even though she's having the, it was a homozygous, right?
Yes, ma'am.
homozygous mutation.
Homozygous mutation.
Yeah, so that could be, but this clearly looks like a dual diagnosis.
Yes.
And interestingly, that Krebs finding that, most of this Menke Henneken has been reported between that 30 to 31,
Yes. Yes.
yeah, exon, and this one is 2. So that is
True.
something which is different. But, as we all know that our population may be unique and most of the prior reports are coming from some other parts of the world.
True, true, ma'am.
So you could be discovering new findings here.
Yes. Yes.
Apart from that, one more thing which I was thinking during yeah, so this resembled the clinical features resembled the primary congenital aphakia when you started.
Yes, ma'am. One eye, definitely.
Yeah, both the eyes. In fact, the
Yeah, the bluish
silvery gray
blue.
appearance in
Yes,
the only
yes,
the
ma'am.
UBM distinguished that yes, this one is like is having a lens and the other one is not having the
Yes,
lens. And I'm
true, ma'am.
sorry if I missed it. Did you operate the eye which had the lens or the
Yeah,
other
ma'am. We
one?
operated the eye which had the lens and not the
Hmm.
aphakic one, because aphakic one we totally did not touch.
Yeah, because the
And
risk for aphakic eye is much, much more higher. And I don't know
true, ma'am.
whether this deformed lens also has a similar kind of risk, but probably
Yeah,
your chances are slightly better.
yeah.
Uh,
We never touch the eyes which have this
mm,
absence of lens, or maybe like some residual lens we really don't touch. And VP also had, ma'am, like irregular waveforms, so we did not want to do anything with that.
Okay. And with this Krebs gene, this particular thing, has the aphakia thing been described or just anterior segment dysgenesis?
Anterior segmental senescence, ma'am, only with the FANCA mutation, not
Ah,
with Krebs mutation
not
of
with the Krebs also.
RTS. No, ma'am, I could not find. I looked for it, and they are describing maybe strabismus, myopia, hyperopia, like refractive
Yeah,
error.
and the facial features and all.
Facial features are there definitely. From ocular point of view, only that.
Mm.
And coloboma is also described in Rubinstein
Yeah.
Davy syndrome, but not per se in Menneke Hennekum. And we
Mm-hmm.
were also surprised by
But
one
in
thing.
FANCA, it can happen, right? No.
Franca coloboma, no, is
No.
not described now. It's not described.
Mm.
So we were also wondering why they chose to report a uncommon mutation like Menneke Hennekum compared to a Rubinstein Davy, which is relatively more common. So that was also in the reporting part.
Maybe your clinical features slightly resemble, that is why, because the Rubinstein Tybee, the clinical features, the systemic features, short stubby fingers and all, they're so striking that
Mm-hmm.
usually they are, they're kind of reporting with your matching with your phenotype that you may have
Okay,
described.
okay, okay.
Maybe. I mean, there are any other thoughts from other people who
Yes,
attended?
yes. Good evening. Good evening. Sonam,
Good
very
evening.
nice case, very interesting. Dr. Sangwan here.
Thank you,
So,
sir. Yes,
so what I would think is that okay, you people are focusing on a mutation in the whole genome sequencing. If you have the tissue from that cornea, I mean, if they're in formalin fixed also,
sir.
or if there is an opportunity when the child comes, if you're doing EUA, if you can take tear samples and see the gene expression and the mutation in the tissue, ocular tissue also.
Yes, yes, sir.
So the cornea, and like if I am operating on this patient, then I would also take conj biopsy. I'll take the recipient button. I will send to the lab and maybe tear sample.
Mhm.
So that may give us little better insight in terms of the what is tissue level expression versus what is there in the whole genome sequence, and then compare that expression with the normal cornea.
Yes, yes, sir. That's a very good suggestion, sir. In fact, the FANCA mutation study that I just showed, they have actually done the transcriptome analysis of the tissue, the corneal button, and
Hmm.
they found this down regulation of the various keratins, KRT mutations, and upregulation of the fibrotic gene expression and everything. Yes,
Mm.
I'll definitely look into it, sir.
And our lab now you can work with Ria and maybe Selja, and they can work with our team, Mehak and Anil, that we will be able to get these things done in our lab. We are able to, think about these. Especially, I pay attention to patients which I'm operating, so I try to give samples as many as possible tissues
Okay.
so that we can start understanding the disease from the affected tissue level rather than looking at traditional mutations and their impact in the whole body.
Yes, definitely, sir. Thank you, sir. I will definitely get in touch with Dr. Shelja and Dr. Ria for the same.
Yeah, that makes really sense and great suggestion as usual. As expected from sir. That
And Sonam, I'm very impressed with your CV. You're so nice. You're doing so exceptionally well.
Thank you so much, sir. I think it's all.
she was remaining hidden all this time. Caught her at UC and then
Uh-huh.
she expressed as yes, you should present. Yeah.
No, very nice. Good, good.
Thank you, sir. Thank you so much.
Okay, okay.
Any other comments or questions? I think there's something on the chat, Ria. Oh no, Gora says she's stepping out. Okay.
Can any of you who understand this crab gene mutation, can you please explain very briefly in a very simple terms what does it mean? Ria or Selja or and Sonam, any of one of you know?
Yeah, basically, so the CREP binding protein, it actually has this acetyl transferase. The product of this mutation leads to the acetyl transferase activity, which
Uh,
actually acts in the histone protein production. And
uh-huh.
mutation leads to abnormal histones in the tissue, and that
Okay.
leads to the damage. So
So
acetyl
basically,
transferase activity.
so basically, it affects the acetyl transferase activity, and because that is abnormal, then there is a backlog and abnormal histones.
Yes,
And histones, and then they are very important for epigenetics.
yes.
Hmm.
Moreover,
Okay.
one more thing I wanted to add in this case, from the anemia point of view, uh, Fanconi anemia has macrocytic anemia, while our child had microcytic anemia. And the features were, of course, the child was anemic. Ultimately, with just giving iron supplementation, over 3 months' time, his anemia improved to 9, even though his MCHC remained low. That's why the hematology team is basically looking into like the thalassemia trait part. And again, I was wondering, the child later on showed neutropenia. So one thing I wanted to point out is that even though initially it could be a microcytic anemia, because these children, usually the Fanconi anemia, later on expresses over the age of like 5 to 6 years only. That's when the hematological symptoms actually manifest. So this was quite early for this child to only have anemia, but later on we did see over a period of 1 year follow-up that the child developed neutropenia, and later on the child may develop complete bone marrow suppression in the form of pancytopenia. So that's another interesting thing that we found in this particular case, the overlap of the hematological features also.
So when aren't they the part of Fanconi's anemia?
Yes, ma'am.
The neutropenia and other things, aren't they the part of Fanconi's anemia, or it is altogether a different thing?
Ma'am, there is macrocytic hypochromic anemia, while in
Mm-hmm.
our child there was microcytic anemia.
Microcytic.
Yes, ma'am. But neutropenia was not present at the time of presentation. But after 1 year, because we wanted to improve his hemoglobin levels, his hemoglobin did improve to 9.9 in fact, but his neutropenia started. So after discussion with the hematologist, that's what they said, that these features like cytopenia usually present at the age of 5 to 6 years. So that's why we are not seeing this, and we are treating the child early and catching the disease early, so that the later on the bone marrow suppression, he doesn't land up like that, because these children are prone to develop myelodysplastic syndromes and AMLs also in future.
Mm.
Yes, ma'am.
Dr. Sonam, I just had one question. Did you get a chance to do the CBC for the mother? Because she was also homozygous for the same.
That's the next plan, because after actually this case I discussed with Dr. Arif as well last week when he was here in Chandigarh. So this is what he also suggested, that we should do a mother's CBC, even though she may not be symptomatic per se, but she could be
Yes.
having some blood.
Because the CBC photo looks a lot like how Thaltrate's CBCs look.
Yes,
And
yes.
so, and you already said you're on that path of ruling out trait,
Yeah.
because labs will trait will be heterozygous for the HBB1 gene. So the lab will not write it down because it's not concurrent. But since you've already done the WES, this literally only asks you to go back to the lab and ask them to look whether the HBB1 has a heterozygous variant, because that might also explain the variation in the CBC of the child.
All right.
In which case, my only apprehension is that the FANCA gene, even though homozygous, is a VUS. So how seriously are we to take it as of now, even though the blood picture matches? So
Yeah,
if we can rule out the more, I would say obvious, or like the more, if they were a thal trait, because and the mother's CBC will give more information also.
Definitely, definitely. So he is now with the hematologist. The child is following up with them, and they are also looking into both the possibilities, because later on, because the neutropenia is starting in now, and it could be just like again double picture of iron deficiency anemia, thal trait, as well as the fanconi coming in.
Yeah.
It's very unfortunate, but yes, so many things.
Yeah.
And with the CREB variant, it's a heterozygous autosomal variant, autosomal dominant variant.
Dominant.
So we could do parental segregation for that too.
Yes.
I understand that the absence of it will not give us too much, but the presence of it might tell us that we don't have the answer just yet.
Yes. Yes.
Because the overlap is so, it's not precisely overlapping with the phenotype, but some of it is. So just based on phenotype, genotype, we are not quite able to say whether to think of it or not.
Yes.
Yeah.
So we have reached out to the lab to look for any mutation, and the mutations that are actually reported for Meniere Hanicum are de novo mutations only so far. So we are hoping that we may find an answer with that.
Yes. Yes.
Yes. Thank you, Dr. Ria, for this session.
Very interesting case.
Thank you.
Thank you. Thank you, Sonam. So, Ria, we move on to the next one.
Yes. So our next case is by Dr. Deepika.
Yeah,
And
I'm just sharing the screen.
okay.
Okay, thank you. I hope the screen is
Yes.
visible. Yeah. Okay. Thank you, Dr. Sonam, for presenting that very interesting case. I think the important, like intriguing point in that is mother being homozygous and phenotypically we have not got anything in the mother yet. At least I think the detailed examination will definitely help.
Yes.
And I guess we need to look more on the variant itself, like Ria was mentioning, like what is exactly happening with the protein and amino acid change downstream to that both CREB and as well as the FANCA gene with respect to the, of course, it is rare. That's what is reported by the lab as well. But with respect to the prediction models, I think it will help us more to chase which one. And finally, it should land up in both or either of them.
Yes. Yes,
Yeah.
Dr. Deep. Thank you.
Thank you. So I'll begin with my case. Thank you, Dr. Shailaja and Ria, for this opportunity. I'll again show one more confusion of phenotype and genotype. And we all know that in between phenotype and genotype, we always keep the phenotype first. So this case, I try to approach both the ways, like phenotype and genotype. And I'll just show you on how the patient presented and what happened to both the phenotype and genotype. Prospectively, what was the thinking, and retrospectively, what was the thinking. So this is a 31-year-old male. He visited to us for second opinion. He was diagnosed or suspected to be having retinitis pigmentosa elsewhere. Apparently, he went for a regular checkup, and this changes in the retina were detected. He did not have any visual complaints. In fact, on visiting to us as well with respect to leading questions, many of the IRD symptoms which we have, the retinal dystrophy symptoms, he did not evidently say yes to any of those. And systemic health was okay. There was no drug history, no family history. There's no history of consanguineous marriage in the parents as well. So this is his fundus picture. Vision is 6/6, N6. Anterior segment was fine. If we can see both right and left color fundus images, what we see prominently is in the left eye. I'm just highlighting over here the positive findings. These pigmentary changes, which we are seeing in superior to the superior arcade, and some nasally as well, and some bony spicules. Whereas in the right eye, these are mainly very subtle pigmentary changes. We may miss it as well by a cursory clinical examination. And if we look at the macula, the reflex seems to be okay, optic disc is healthy, and blood vessels are normal. And this is what the autofluorescence shows. So the autofluorescence is very, very important in retinal dystrophies because it reveals more than what we see clinically. And it also highlights the pattern, symmetrical nature, and it correlates well to the OCT features and patient's vision. So that's how autofluorescence is a mandatory and must test in retinal dystrophies, especially the wide field autofluorescence is preferred. So in both the eyes, we see that this okay, in both the eyes, we see hypoautofluorescent changes, nasal to the disc and superior, which is clinically correlating to what we saw, the pigmentary changes. And if we come to the central macula, so in a normal situation, the center will be hypo, at least in the imaging which we have done. If we look carefully at the utmost center, even in the right and left, we see that there is a speck of hyperautofluorescence, and then there is hypoautofluorescence. And the background just surrounding to that, what we are seeing is this hyperautofluorescence. So this is also not even normal. So there are various changes which is happening in the autofluorescence, which indirectly tells us about the photoreceptor and retinal pigment epithelium health of the patient. So this is,
Deepika, please stay there.
yes, sir.
Look at the central macula and fovea. Both are very different.
Yes, sir.
Right and left eye, if you look at the in terms of the black part, in the right eye, this is quite narrow. In the left eye, it is so wide. Yeah, this area. If you see this, why is this difference? Is that also tell something about RPE or underlying structures?
Okay. So this could be due to two reasons, sir. One is definitely the level at which the photoreceptor health is dipping. Like I'll show you the OCT correlation next. That
Okay,
is
fine.
one
Go ahead.
possibility.
Go ahead. Yeah.
And the other is in optos, when we take this image in optos, if you can see, there is slight tilt which happens because the angulation is different. So if that has caused some change in this, I'm not sure. But the broader hyper white thing over here could be due to the degenerating photoreceptor RPE, which I can think of.
Okay.
Yes, sir. And this is the OCT picture, which we see over here, the central OCT, central macula, right eye and left eye. In the right eye, we see that the foveal contour is okay. And as we go down, this is the outer nuclear region. Usually this will be like black or hypo. And this is that is hypo, thickening of the external limiting membrane, which is over here. And just subfoveal region, the photoreceptor and retinal pigment epithelium looks okay. As we go to the parafoveal region, there is thinning, which is starting very early at the outer nuclear level, outer nuclear layer level, and then there is loss of ellipsoid zone as well as thinning of RP, which is developing. And to correlate it to the autofluorescence, it's been well studied that the autofluorescent ring, or the broad or the narrow ring which we see, it correlates well to this thinning of the outer nuclear ellipsoid zone and retinal pigment epithelium. So autofluorescence ring is an indirect measure of what is happening in the OCT, and when the structures inside the ring are good, it indicates a good vision, and this patient definitely had a 6/6 vision. We also see some cystoid changes at the OPL and inner nuclear layer in the right eye. Left eye again, a similar picture. Important highlight here, unlike just the regular retinitis pigmentosa thing which we see as parafoveal outer retinal loss, is the highlight of this external limiting membrane thickening or hyperreflectivity, which we call, because there are some genes, genotypes, which are known to cause this kind of OCT phenotype, which I'll be showing further in the slides. And probably like what sir was asking here, if we see the length of the outer nuclear layer, also the preserved ellipsoid zone is slightly better here temporally in the left eye when compared to the right eye. Although we have to pass the scans through all that broad area like a raster scan or through the lines and radial scans and compare it. But this is also one reason which could be providing those kind of pattern in left eye autofluorescence. So I was very interested in this point, external limiting membrane thickening, because we do see this in mucopolysaccharidosis cases, the MPS type 1 and other types as well. It is known to be causing due to the glycosaminoglycan deposition at the level of ELM and outer nuclear layer. So I was thinking, though it is an adult patient with no syndromic or systemic features, could it be that non-syndromic or isolated retinal degeneration related to mucopolysaccharidosis, and some late onset mucopolysaccharidosis are also related in adult one, not just the I'm not referring to MPS type 1, but the other ones. So then finally, as usual in retinal dystrophy, for all cases, we do a functional phenotyping as well. So far, what I described is structural phenotyping. So in functional phenotyping, the pattern ERG comes the first. Because his vision is 6/6, that doesn't mean that he has good functioning retina at the central macula. So we need to assess the function by pattern ERG. The normal is on the right, where you can see a good P50 waveform with the amplitudes of 5.8 microvolts. Whereas when you come to right and left, we see that there is gross reduction of P50. P50 indirectly represents macular photoreceptors health. And in P50, right eye 1.84 is the microvolt is the amplitude, and in left eye it is 2.2. So here there is both eyes central macular photoreceptor dysfunction, which is highlighted by pattern ERG. Then we go for full field ERG, which tells us about the global retinal function. So in autofluorescence, we saw that the sectoral changes were mostly in the nasal area, but it doesn't mean that the disease is limited to the retina functionally. So that's how the full field ERG helps us. And when we look into the full field ERG, scotopic, that is dark adapted responses, I've kept the normals on the right. So we can see that this is the dimmest flash, dark adapted 0.01, where we see that the B wave is grossly reduced to almost undetectable. And when we move to the further brighter flash, that is dark adapted 3, that means we are stimulating with a brighter intensity now. So here again, there is reduction of A as well as B wave. It indicates that there is dysfunction or less functioning of rods, both at photoreceptors and bipolar cell level. Predominantly, it could be at the photoreceptor cells, because the B wave is as a result of A wave reduction. So further, going into brighter flash ahead, it is dark adapted 10. This is again showing the similar picture. So in dark adapted, that is scotopic responses, there is severe dysfunction of rod photoreceptor cells as well as bipolar cells. So this is what is happening at the cellular level in the retina. Now I'll go to the photopic, that is the brighter light which we do. So light adapted 3 ERG, when we compare to the normal, it is severely reduced. In fact, it is more reduced than the rod waveforms which we just saw in the previous slide. And the next light adapted ERG which we do is light adapted flicker. Both represents different forms of cone function. This is again severely reduced. So we have a patient which showed us by autofluorescence that it is mostly a kind of sectoral degeneration and some involvement of macula. But when we do an ERG, it is more clear that the patient has both dysfunction of cones as well as rods, and the cones are more affected than rods. So now the phenotyping with respect to functional component is called cone rod dystrophy. This is all important when it comes to the genetic report, and we try to correlate. That's why I am trying to highlight both structural and functional phenotyping. So this is a multifocal ERG. In addition, we do this to assess,
So,
further function.
Deepika,
This is again
sorry,
reduced.
Deepika, can I interrupt
Yes,
here a
yes,
little?
doctor.
Yeah,
Yes,
yeah.
please.
So, very interesting because many times, when we see this report and we see the vision is 6/6, how can it be both cone? I mean, there could be cone involvement as well. Also, there is an absence of photophobia here,
Yes,
any nyctalopia here. Despite
yes,
that, so the symptoms and the function and the symptoms, they are not kind of correlating. They are even with the OCT, the central macula was quite good. At the same time, the cone responses. So that's because ERG gives you a more pan retinal or kind of full retinal evaluation rather than the center. So just the center is okay and rest all is involved. So it's very important learning from this case. When we based just on the symptoms or the autofluorescence, we can't label it really a rod cone or cone rod. So for that you really need an ERG to call it rod cone and cone rod. Am I right?
yes, definitely, absolutely, Dr. Shailaja. Also, with respect to the cones, though we say that I think the density of the cone is more at the center, but majority of the cones are still situated along the arcades
Outside.
and
Yeah.
mid periphery.
Hmm.
So that's how the full field ERG will pick this up better than we just correlating for that centermost, BCVA, which we measure by Snellen.
Yeah.
So
And
that is one thing.
even the pattern ERG, the P50 was
Yeah.
slightly reduced. Otherwise, that can sometimes be normal when the full field is reduced.
Yes, that can be possible, or it will indicate that soon, the function is going to reduce so much. It has already reduced that it can affect his vision in the future, possibly, in another in the follow-up years or months, probably, because function has gone already. Definitely, the structure will be affected. That is one thing which we can think of. Okay. All right.
Yeah.
So
Thank
this
you.
is again multifocal ERG. Sorry, it is going more in favor of ERG than genetics. I'll
No,
come
no, no. It's
now.
it's good. It's good.
Sorry. Because I feel that the complete phenotyping is very important for
Yeah,
retinal
yeah.
dystrophies before
Agree.
we jump. That's why.
Okay.
So to summarize, he's a 31-year-old adult male who's healthy, apparently no complaints. And probably I feel that the question which you asked is very, very important because we do encounter a lot of patients, like where I'm seeing fundus is typical RP with lot of pigments and ERG is like totally flat, but they still say that, no, I don't have any problem. So that is one is because the variation in the environmental conditions which every patient stays. Some may be just in the well-lit environment, some may be just inside the house, and they might not have so much visual requirement or visual activities, their day-to-day activities, by which they can recognize all these, slight changes of delayed dark adaptation or, minute photophobia, some things like that. So, but a detailed probing history is the key over here.
Mm.
And okay,
Do
no
you
positive,
do dark adaptation test
like
in the clinic?
dark adaptometry.
Mm-hmm. No,
No,
right?
no, no, not yet,
Mm-hmm.
not yet.
Hardly
Dark
any
adaptometry.
place does it. I mean, if anybody knows where
Mm,
it is really done. Like in clinic, you can just compare it with your dark adaptation by
correct.
making the room dim light and do it. But
Mm,
really, nobody does it because that could really solve this mystery whether really there is a night vision problem in the patient or not.
he
Mm.
should, yeah, he should have definitely, because the
Definitely, yeah.
ERG is one test, which is not affected due to a subjective nature.
Correct.
So we can do it in a patient who is not even fixed, who's having very less vision to who is having good vision. So
Hmm.
maybe his environmental conditions, or we might have to probe more. That is one thing which I thought. So structural phenotype, sectoral pigmentary changes with macular involvement, which we saw in OCT. OCT parafoveal loss with ELM voinal hyperreflectivity. Functional phenotype, it is a global cone more than rod dysfunction along with reduced macular function as well. So I sent the patient for genetic testing. So in genetic testing, what came was CDHR1. Totally something which I was not thinking. I was more in favor of where we see ELM hyperreflectivity or that ONL hyperreflectivity which we were seeing. So here the report says that there is a missense variant in exon 12 of CDHR1 gene, which is just heterozygous. And CDHR1 pathogenic variants, when present in an autosomal recessive pattern, can cause these all phenotypes: cone rod dystrophy, retinal macular dystrophy, and retinitis pigmentosa. Whereas in this patient, it is one variant reported in an autosomal recessive condition. At the same time, it is uncertain. So it becomes too complex whether we are missing something, or whether we have to really chase this one variant which has come up, because there could be something missing in the genetic report as well. So I started to do a kind of phenotype relooking, and then again genotype relooking on whatever is reported. So that's where it lands up, and we have some phenotype clues which we can try to think of, okay, this could be, that could be, but then we find genotype of something else. This is very often in retinal dystrophies and even other conditions as well, especially when we are learning. So this is what is happening, and we all do kind of retrospective correlation to genotype phenotype. So these were the two things which were in my mind when I saw ELM thickening or OLN hyperreflectivity, mucopolysaccharidosis. Retinopathy is known to happen in these all mucopolysaccharidosis, MPS 1, 2, 3, and 4, though there are till 9 MPSs. But the MPS 1, 2 or like congenital onset, I'm sure you all will know more on my mucopolysaccharidosis because of the corneal clouding, pediatric presentation, syndromic appearance. So that's how it is. That is what is in mucopolysaccharidosis. Another thing, what we have noted, this hyperreflectivity is also in CLN3 Batten diseases, which is in case of non-syndromic RP cases are also reported. So the Batten disease, though the Batten disease is mostly, when we see the kids, they will be in their first decade, but non-syndromic retinitis pigmentosa are also reported. But anyways, these things were not there in the genotype, and I tried to look into all the genes of mucopolysaccharidosis and CLN3 for their coverage under the clinical exome sequencing which was done, and it was found that the coverage for all these genes was 100%. Then MPS, all these features which you can, obviously our patient did not have anything of this. Retinal degeneration was the only sign, and probably I was thinking only the late onset or the milder forms. Why I was stucking into the MPS was, this was a project during my fellowship at the Hospital for Sick Children, Toronto, where I had analyzed MPS eyes, and we found that this thickening of foveal ELM, MPS type 1 it was, foveal thickening ELM was seen in almost all the cases, and with some showing the degenerated changes as well. And this is quite specific, and it is reported in many of the other studies as well. Then I went back into the genetic testing to look closely into what is this variant, whether I really have to go behind this or not. So first I started with the genetic finding. Then I retrospectively went to the phenotype of CDHR1. So here the lab said that the variant has not been reported in 1000 genomes nomad. So that means it says that it is a very rare variant with a minor allele frequency of 0.002 to 1%. And the in silico productions by the lab, by their in-house actually, polyphen 2, it was damaging by SWIFT and LRT. Reference codon is conserved across species. So whenever it is conserved, it is good, because any change, whenever it is conserved in a good, in across the species, it is good, because any change becomes significant. And when I put this same variant in the Franklin genox, it showed extremely low frequency in all the kinds of nomad-based population databases. We do have some Indian data as well in that. And aggregated prediction score, this is for the in silico predictions, it was around 0.84. And anything based between 0.8 to 0.9, I think, will come to this grading of ACMG, that is PP3. So PM2 is for the variant which is not common, and PP3 is for the prediction model which is saying that it could be pathogenic. So I thought, okay, it is, I think, still be damaging. Then I thought, okay, I will look into the phenotype again of CDHR1 reported and compare with my patient which I saw. So CDHR1 retinal dystrophy has been reported, and the phenotypes which are described are the same, which the genetic report was saying: cone rod dystrophy, macular dystrophy, or retinitis pigmentosa, which in turn is just a rod cone dystrophy. And mean age at presentation, 42 plus or minus 13.2 in the studies which have been reported. And when it comes to cone rod dystrophy, the pattern which is seen in this patient right now, it comes to 23.2 plus or minus 17. Again, the standard deviation is too high. So we can understand that the age of disease onset is from young to even adult. Again, the visual vision is also very varied, from hand movements to 20/32. That means good vision is also possible if it is detected early. Then I thought to look into the phenotypes described in the literature. One common thing which we can see in all the photos, these are the fundus photos and these are the autofluorescence, fundus and autofluorescence, is this involvement of the macula. And it is more severe, like a kind of atrophic patches, and the involvement of macula looks to be more prominent than just the periphery, although we don't have wide field images, but the by autofluorescence we can get the clue. Except for this, one patient, majority of them have severe macular involvement. And this is again another forms of CDHR1. Like this middle one is macular dystrophy, this is a rod cone dystrophy, and this is again a rod cone dystrophy, where we can see that the macular involvement is more. Though I thought that this much macular involvement at this point is definitely not there in our patient. Whether it will develop in future or not, not sure. It's again, the phenotype is also not clear, like because we have only one specific point, and it can also be seen in many other diseases as well. And the genotype, having found only one variant in an autosomal recessive, and then again it is uncertain. So, and it is clinical exome sequencing. Right now, I'm just waiting. We are not doing anything for this patient. We are trying to follow him for the evolution of the phenotype in retinal dystrophy. Very, very important point, because unlike, the cornea one which we saw, and also many of the pediatric disorders which we saw, the phenotype is present. It is always present. Whereas in retinal dystrophy, the phenotype is present, but it evolves so much that if you see a patient at 30 years, if you see a patient at 10 years, it will be entirely different. So we have to give enough time when we don't understand the disease, and not make broader conclusions without having conclusive evidence by gene or genotyping. So we need to wait for the evolution. So evolution, definitely by what we are seeing in the function, that is the strongest test, ERG, pattern ERG, the patient is unfortunately likely to progress to more macular involvement, and generalized retinal dystrophy changes or can develop in other parts of the retina as well. And in the genotype, whether at this point it is very early and we are missing the CDHR1, another variant, we don't know, or if there is some other genetic variations in other genes which can also cause similar phenotype is missed, or larger deletions or intronic, or genes which could be causing but not covered in the current clinical exome sequencing. Those are the possible situations. I would like to take your opinion on how you solve these kind of cases when we have a little bit of phenotype points and then we find a very different gene which is also not matching. Do you go behind, doing further more tests, I mean, with respect to genetic tracking, or we wait and follow up or reanalyze the report after 2 to 3 years? Any similar situations will help us. Thank you.
Thank you, Deepika. Again, wonderful, thought-provoking case. And believe me, we are also stuck many a times with these kind of situations. And there could be, additional tests you can do later on, thinking about, what you have missed. Like you are saying, large deletions, duplications might have been missed. So you can go ahead with other kind of tests. But that could be one kind of thing. Only thing which I was thinking that yeah, okay. I thought my internet went off. So I was thinking that are there any reports of this CDHR1 gene causing milder symptoms in a heterozygous state? Could that
No.
explain
Mm,
your lack of macular involvement, that extensive macular involvement, that because this is in a heterozygous state,
mm,
maybe it is not causing the full disease, but causing, some part of the disease there. That's why he has a very good central vision as of now. As you're saying, he may evolve, but that is something that you could look into and see whether it
Like a
kind of fits
dosage
there.
dependent effect.
Yeah,
Genes
yeah,
are quite
maybe.
dosage dependent.
Yeah, that could be there. And looking at the mechanism and what's the downstream pathway, what happens to the protein, and maybe that could be, I mean, I don't know, maybe, but that could hint why this phenotype is not the exact matching of what has been reported so far for this particular gene. Because otherwise it kinds of fit, it fits little bit. I mean, not very much, but yes, it's a retinal dystrophy. It's a cone rod dystrophy. By your ERG, you're getting a cone rod dystrophy, right? Which is the most common manifestation or a phenotype associated with CDHR1. So that is one thing, and maybe again, Ria can highlight what next can be done to, check for the other genetic variations.
Yeah, I think the yield doesn't really, as per literature and people's experiences, increase after going from CES to WES or
Mm-hmm.
Exome Max for that matter. So I don't think that would be. It's better to look at it again in a year or two, like you have decided.
Mm-hmm.
The other thing is, I would have just asked the lab if they found any missing gaps in the NGS data that would hint if there could potentially be a deletion duplication on the other allele that I should try to chase. I wouldn't straight away try to order an MLPA, just get that much information whether they have any missing gaps that could point towards a potential variant that was missed. Um, yeah.
What is MLPA, Ria?
Sir, it's multiple ligation probe amplification. It is a gene specific technique to check for large deletions and duplications, which gets missed by next generation sequencing.
Oh, okay. Deepika, I have very unrelated question.
Yes, sir.
How did you convince your patient to undergo so much of investigation? And what did he get at the end? If he has no visual problem, then how what do you think how you are helping?
Yes. Okay. Okay. Very thank you. Thank you, sir, for asking that question. That's what I try to do for almost all of my retinal dystrophy patients, from no vision problems to severe vision problems. I try to talk to them, advise them to do more investigations that we understand better. Particularly coming to this patient, he was very educated. He was also curious to see that changes. I totally showed him all his images. I did not scare him. That was my first point. I told him that you don't have any symptoms, don't worry. So that is the first line which I told him. The second was I showed him the normal OCT, normal autofluorescence. Then I told, okay, these are the changes. This could be evolving. We don't know how it will evolve, but it is always good for us to have more information at the beginning or at the initial stage of these changes, because this will definitely guide us, or we can help you on understanding whether it is going to be a severe progression or a milder progression, or is it going to be passing on to the next generation or not, because he's a very young chap, like 31-year-old. So if there is something genetic going on, and we should not be missing that point of familial genetic counseling. So that way I try to do the same for all patients. And luckily he was understanding, and he was very appreciative actually for all the changes which I showed, and post ERG also. And at every step I told him that though I may give the ERG report as severely reduced, you don't worry, okay, unless you have any problem in your day-to-day activities, we are not going to chase anything. So that was the point. And post genetic testing, now we have concluded him that because we do explain that 30 to 40% of the times it will be something negative, or we will not find anything, but that doesn't mean that there's no genetic relation for this. We will definitely reanalyze after 3 or 4 years, that way. We have done it. Yeah, it depends on the patient, but we do take time and then ask them to go ahead for these investigations. But I don't scare any of my retinal dystrophy patients. That is the tagline.
No, Deepika, if you scare or not, but if I am your patient and you do so many tests and then you say कि हाँ सर कोई कुछ चिंता की बात नहीं है, लेकिन ये ARG भी reduced है और कुछ RP changes हैं, हम 2-3 साल के बाद देखेंगे. तो basically I mean, this is my clinical, perspective. Ki if I'm not able to alter the course in any way, so if you are studying, if you're doing a research and you're say, okay, I want to understand, and if the patient is okay with that, like for example, I take a patient, keratoconus patient blood sample, I tell them that it is not the test which we are doing is not going to help you, but it will help us understand the disease better. So maybe next generation, maybe next in future patients we may be able to do something better. So if you are doing for that purpose, that definitely is worthwhile. But for an individual patient, unless you counsel them in a way that see, it is more to understand how these disease or how these patterns behave over a period of time, so that we can learn and understand better. But in your individual patient and individual case, we will not be able to do anything.
Yeah.
Basically, we are just going to watch and repeat tests.
Yes, sir, definitely. I agree. 100% I agree. This is in terms of what came up in this patient's genetic report. But imagine if something else had come and it was positive. So that will change the scenario entirely. So that is what is the attempt here in all retinal dystrophy cases, because we know that we don't
नहीं नहीं नहीं,
actively
मेरा
introduce.
मेरा नहीं नहीं,
Yes.
मेरा एक ही पॉइंट है कि अगर उसको सिम्टम नहीं है तो इतना ज्यादा, क्योंकि आपका इंटरेस्ट है रेटिनल डिस्ट्रॉफीज में, तो यू वेंट आफ्टर दिस. इफ आई एम सीइंग दिस पेशेंट, आई कहूंगा छोड़ दो, डोंट वरी अबाउट एनीथिंग, इफ देयर नथिंग, जस्ट लेट अस सी, लाइक कैटोकोनस पेशेंट. हाँ, हम 6 महीने में आपका ये करेंगे, बट ऑल इज गुड. इफ यू यूज ग्लासेस, you use your contact lenses.
Yes, sir, but I would want to differ with that, but because I think he came with a diagnosis of a retinal problem to you already, right? Somebody else is diagnosed and then
No,
referred.
no.
I
Yeah.
think there
No,
was,
no.
yeah,
He came for a second opinion on whether it
second
is
opinion,
retinitis
yes,
pigmentosa or not.
yes.
वो
They right.
क्वेश्चनेबल था, उसको विजुअल सिम्टम्स नहीं थे, किसी ने
Ah,
क्वेरी डायग्नोज किया रेटिना देख के
yeah,
Yes,
कि
yes.
भाई हाँ, मतलब ऐसे हो सकता है, तो इसलिए एक बार ये डॉक्टर साहब हैं एनएन में, उनको दिखाओ, वो स्पेशलिस्ट हैं.
जी, जी,
Yeah.
बिल्कुल.
So that is true. Like I think we have a
So
better diagnosis for him now than he just
what
searching it
he's
as
done,
retinitis
yes.
pigmentosa in Google. I think
Mm-hmm.
Yeah,
correct diagnosis is the
I
So
right.
think that is,
you have taken care of his curiosity, and you have given a more detailed scientific explanation कि देखो, this is what we think that is what happening, and this is what the evidence is.
yeah. Yeah, but apart from that, as Deepika is saying, that if there had been some concrete report which had come, which could have helped him in his family planning or future, and we could have gone with a better kind of a post-test counseling for him. Just because the test did not come,
No, no, I
uh,
understand. I
yeah,
understand that perspective. I
then
understand.
that would have really helped him. So we start with the hope that we can give them 100% answer, but that is not possible in all of these cases, because there are limitations with the genetic testing. There is a
अरे भाई,
limitation with
जस्टिफाई
the
मत करो, आप जस्टिफाई मत करो. मैं आई एम
नहीं,
जस्ट
तो क्वेश्चन वैसे ही पूछ रहे थे, जस्टिफाई तो करना
वो
पड़ेगा ना
नहीं नहीं,
सर.
मैं दीपिका को थोड़ा सा, आई वांटेड टू गिव हर लिटिल मोर, बिकॉज मे बी हिज हर पेशेंट इज नॉट गिविंग हर दैट हार्ड टाइम, सो आई जस्ट गिव लिटिल मोर चैलेंज.
या अग्री.
Then
ये सब
it is yes.
क्वेश्चंस लेकिन एक्चुअली पेशेंट पूछते हैं फॉर द पीपल हु आर अटेंडिंग, एंड रियली द फर्स्ट थिंग दैट दे आस्क इज हाउ इज द डायग्नोसिस गोना हेल्प देम, then the immediate family members, and all these things come up because it's an expensive test. Apart from that, if we say नहीं नहीं बस diagnosis होगा और कुछ treatment तो है नहीं, तो that deters many of them to go ahead with this testing. Mm. So, but if there's a curious patient like hers, then they go ahead with
क्यूरियस एंड अफोर्डिंग.
yes, and affording. Yeah, both matters.
Yeah, I think it is good to keep it open to the patients as well. It is up to them what they want to choose, how they want to go ahead, and better to give more scientific evidence than just asking for a follow-up after 1 year. So that's what we do, retinal dystrophy, because ultimately we're not doing anything actively, right? At least a few more years. So definitely, I think giving the right diagnosis more scientifically will help for them
Yeah,
to
but
settle
there
down
are
in their
some.
Yes.
mind too,
Mm.
at the first sitting.
Yes, definitely.
There are some gene therapy trials going on for this CDHR1 also, some AAV related. I don't know how much they are into their course of path of success, and but just I was flipping through before your cases popped up that there is something going on. So maybe, we hope for the best for these patients. Any other questions from any of the attendees? If not, that thank you so much, both Sonam and Deepika, for rising to the occasion and kind of preparing so in a short time and presenting these cases so that our September month is also the tick mark of that. Okay, has happened and wonderful cases. I had not expected कि इतना jaldi. Of course, both of you are great presenters, great clinicians, but इतने
And
jaldi.
very well worked up.
Yes,
Very
yes.
well worked up.
And sir, instantly ready. 2 दिन पहले group में we discussed and they have the cases ready. So really commendable. And please don't thank me or Ria for this. All this is a collective effort from the entire group. And I was discussing with someone, I think Savleen, and she was saying that our OGIG, the discussions are much better than any other discussion groups in genetics. So thank you for to all of you for making, and please don't thank us before presenting. It's not like a formal thing. So we all are learning from you guys.
All right. Thank you, ma'am.
Thank you, everyone. Thank you, sir, for the
Thank you,
comments.
sir.
Thank you. And
Thank
Dr.
you, sir.
Sangwan, thank you so much for joining us today.
Yes, thank you
Anyway,
very much. Thank you, Deepika and Sonam. Wonderfully worked up cases.
Thank you, sir. Thank you
sir.
for all the suggestions.
Yeah,
Yes, sir.
bye.
More comments, probably practically challenging. We will understand more from you.
Thank you. Thank you.
Thank you.
yeah.
Thank you. Bye, everyone. Thank you.
Thanks.
Bye. 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 Bye.